Good afternoon, everyone. I think we'll make a start, and I'd just like to welcome you all to our next ABMC Research in Review, and today's is going to be focused on SAMRI in neoplasia. So my name's Professor Lisa Butler. For those of you that don't know me, I'm a prostate cancer researcher and I direct the solid tumour program at SAMRI, as well as heading my group and being an associate SAGENCI group leader. Before we start, I'd just like to acknowledge and pay our respects to the Kaurna people, the traditional custodians whose ancestral lands we gather on. We acknowledge the deep feelings of attachment and relationship of the Kaurna people to their country, and we respect and value their past, present, and ongoing connection to the land and cultural beliefs. So today we'll be hearing two presentations from two of our very talented SAMRI cancer researchers, one of whom will be quite new to you, Jordan Hansford, and he'll be running off to see some patients straight afterwards. So without further ado, I'm going to ask him to share his screen. And for those of you during the talk, if you have some questions, please type them into the Q&A box at the bottom of the screen. So thank you, Jordan. So Jordan, just as means of introduction, is a clinical pediatric neuro-oncologist, and he's been recently recruited to head the pediatric neuro-oncology stream at SAMRI. He was also cross-appointed with SAGENCI while working to establish the standards of practice and referral pathways for proton radiotherapy at the new Bragg Centre. Now, Jordan attained his Masters in Cancer Genetics in Canada, as you'll hear when he speaks, at Queen's University, and did his medical training at the University of Sydney. He's keenly interested in improved diagnostics for paediatric brain cancer and for improving survivorship for children with brain cancer. So thank you, Jordan. You can start your talk.
Hi, everybody. Apologies. I am literally triple booked, and I apologize because I will have to run off. There's my contacts. If anybody has any particular questions, you can hit me up at the university email or SAMRI or my hospital email. So I've got 8 minutes apparently. So I'm going to rush you through as best I can, kind of some of the things we're looking at, some of the things we want to do, and some of the things that we hope to do over the next while here in Adelaide. I always like to put in a declaration. I do get a little bit of honoraria for consultation around drug use in children. So brain cancer, for those of you who don't know, is actually pretty common. So about 1 in 4 or 5 kids who've been diagnosed with cancer in Australia has a brain tumor. And in Australia in 2019, that meant about 250 kids were diagnosed with some sort of brain tumor. Unlike most of our pediatric cancers, which have seen incremental increases over the last 50 years, tumors of the CNS really have stagnated in terms of survival, and so we need to do a lot better. It is the biggest killer of children, so we need to do better. What's really happened over the last 10 to 15 years is that we've appreciated that the diseases we thought were one entity are not. They are multiple subgroups, like we see in leukemia from the 1980s when we started doing different techniques to determine that tumors were different than what they actually were. We're seeing the same things in brain tumors. So medulloblastoma is now thought to be 12 unique diseases, each with different risk stratifications and molecular drivers. Ependymoma, similar stories, and that goes now across all of the disease types, including those a bit rare like pineoblastoma and ATRT. And so we need to be thinking better about how we're diagnosing children to understand their disease better, to diagnose them better, and treat them better. This led to kind of the seminal work that we contributed to in the publication from Nature in 2018, using methylation array-based classification of brain tumors, which has now elucidated nearly 200 different subgroups of tumors. And so we wanted to bring this into Australia to help improve risk stratification diagnostics in Australia. It is now standard of care that kids have advanced testing. And so when we started this program many years ago on improving diagnosis, it was to the forethought that in 2021-ish, that we would be looking at major changes. And now it is written into the WHO for a full complete diagnosis. You need to be having advanced testing, including methylation profiling. Our study scheme, essentially, long story short, was to take the gold standard of the work done in Germany, implement it here in Australia, make sure that our testing results were the same. And we basically have shown that we get the same results in Germany. So since we opened, we've had on our study AimBrain over 300 kids. I think it's closer to 350 now. This was to August of last year, who have been recruited onto the study and use this technique. Vast array of different diagnoses, and we'll work with Melissa Davis to start understanding more of this data as we move forward, who's now also been appointed here in the Adelaide district. But the big take home is that 15% of kids enrolled in this study had an alteration or a therapy implication to the diagnostic tool that we were using. 15% of 250 is nearly 50 kids. So 50 kids who've had a major change in their treatment or alteration in regards to therapy because of this type of testing. So we think this is pretty important. If we can treat those 50 better, that increases our survivals, we think, much better. We can also do lots of different basic research. So we've published on new tumor types, risk stratifications on tumors based on the molecular profiling that we get. We also want to look at holistic care of kids with brain tumors. So this is just some advanced tractography using novel imaging to try and understand where the brain tumor is sitting in regards to different fibers and tracts around the body. We can do this. So if we can then do this up front for all kids, we can target in better, have less disability post-surgery. We can also hopefully diagnose the tumor before we even go in using radiogenomics. And we're doing some work with several of the people around the city in the next while. Here's an example of what it does. And basically at 3 months follow-up, this girl was completely well post her surgery. There was no deficits. So the other thing we want to do is look at our outcomes better. So this was a paper from Toronto in regards to remodeling using metformin as a remodeling agent to help with brain repair. It led to an early phase, basically a pilot study. It's published now in Nature Medicine, and it's led to our development of our phase 3 placebo-controlled study of metformin to improve cognitive outcomes in kids who have to be treated for brain tumors. So these are just a touch of some of the things we want to be doing. So the opportunities we kind of see is with the proton coming in, all the pediatric patients will be coming here. We need a prospective survivorship program that there's great opportunities to ask research questions around. There's questions we want to ask about the role of the immune response in response to proton therapy, the genomic role of responses, either good or bad. And so that we really think there's a huge collaborative opportunity here on campus in Adelaide with the new machine coming and the different things that we have up and running. So I'm happy to entertain questions, but I have to run shortly. How was that for minutes, Lisa?
That was excellent. Thank you, Jordan. Very impressive. So are there any questions from the audience or from Dan even? I'll keep the Q&A open for the moment. But Jordan, can you tell us a little bit more specifically about the proton therapy unit and what impact that's going to have on the work you do?
So yeah, it's a good question. So we anticipate on numbers that based off of the MSAC approvals on who can actually get proton therapy when it comes, that for pediatric and young adults, we're probably looking at an influx of patients of about 170 kids a year, maybe up to 200, 210. That's a big workload increase for a unit. So Women's and Children's is a pretty small unit in regards to cancer care with about 65 to 70 diagnoses a year. So at any one point when they're in for their 6 to 8 week block of radiation therapy and workup, you're going to have about a 30% to 40% increase in pediatric care. Some of these kids will be on clinical trials that need specific follow-up, blood tests, chemotherapy. Some of those will be inpatient chemotherapy. There'll be outpatient chemotherapy, clinical reviews, of course, as well as proton therapy happening. And so it's really going to have a broad impact on the community in terms of how we care for them. We need a lot of work, a lot of recruitments, because the staffing that's currently in place certainly can't do it all.
Yeah. And in terms of collaborative opportunities, in terms of research side of things, yeah.
Massive. I want every kid who walks through this door that we have an agreement in place with their base hospitals. We want their genomics, we want their epigenomics, which would have been done at their centers or collaboratively nationally, but we want that data as well so we can track it. We want to do blood tests when they arrive. I want their CSF if we can. Maybe we should be collecting feces to look at microbiome and immune responses that we see in the kids, abscopal effects with radiation. There are so many things that we could do because it'll be one center where all of these families come to. So if we can engage them in terms of a research policy right from the second they walk through, they get their treatment. But when we have to do a blood test, we're going to store some. When we have to do a lumbar puncture for something, we're going to store some extra. When we have to grab a poo sample, we're going to grab a poo sample. Whatever it is, there's a real opportunity. We can store it, bank it up. We got to get that up and running for brain tumors in particular, working on it. But there's so many things we can add. So I had a call yesterday about patient-reported outcomes during radiation therapy. Again, things we need to build towards to make it a better and more cohesive unit for our families.
Yeah, agreed. Yes. Look, it sounds fantastic, and I'll be very interested in watching your progress, because I'm sure prostate will be at some point following along behind in terms of use of proton therapy, and I think setting up those pipelines where these sorts of collections are automatic is really the holy grail, and is still surprisingly so rare in translational research. So thank you so much, Jordan. Realize you have to run off now, but thank you very much for your presentation.
Thank you all. Take care.
Okay, so next up we have Dan Thomas, who will be well known to many of you. I'll just wait for him to share his screens, but just by, again, way of introduction, Dan Thomas is a clinical hematologist and pathologist who leads the myeloid metabolism lab at SAHMRI, and he's also an associate professor of medicine at the Adelaide Medical School. So Dan trained with Professor Ravinder Majety at Stanford University in California, and he developed a suite of CD47 anti-tumour biologicals that are changing the oncology landscape before returning to South Australia just before COVID as a centenary fellow. And he's certainly been making an impact ever since, and someone that I certainly enjoy talking with and collaborating with. Dan's a medical graduate of the University of Adelaide and is a passionate educator at the bench and the bedside in molecular medicine, and is also an advocate for the preservation of South Australian biodiversity. So thank you, Dan, and take it away.
Thank you, Lisa. I'll just unmute myself. We have a cancer metabolism epigenetics journal club that students or others are very welcome to attend on Mondays on level 4 in the SAHMRI boardroom. My lab is really trying to find as many mutation-specific vulnerabilities as we possibly can across many cancer types, and we have been integrating computational tools that we have developed with mass spectrometry, metabolomics, as well as shRNA and CRISPR screens, mainly using patient material or isogenic human lines and humanized mouse models. As you well know, now in South Australia, younger and older patients with cancer often have access to tumor sequencing, either whole exome or targeted hotspot next generation sequencing, and that will give their clinician and the patient a report of potentially druggable mutations that could help the patient enter a clinical trial, for example, under the MOST or PRISM program, or sometimes alert them to a kinase therapy or a repurposed medicine that could potentially be life-saving. That's really the idea of MDTs, but unfortunately about 85% of the mutations we see are mainly considered undruggable. And so my research is really aimed at improving the prognosis and trying to find novel ways to targeting driver mutations in cancer where we consider these undruggable. And we've used a number of approaches, including synthetic lethal, epigenetic and differentiation therapy, as well as neoepitope therapies that we're currently developing that have been really exciting. I use acute myeloid leukemia and myelofibrosis as my test bed for precision medicine. And we have drug discovery target programs for the mutations that you can see in red boxes here. The reason I use myelofibrosis and AML is not only we have lots of patient samples here in South Australia at SACRA, but also the karyotype of these tumors is often normal. So you know that the mutation profile that you're looking at, the variant allele frequency, is probably driving the tumor. And so it gives you more confidence that you could possibly come up with a mutation-specific therapy. So here are the key questions that I ask when reading a cancer sequencing report. First of all, which driver mutations are present in the dominant clone of the tumor? We now realize tumors are like a Death Star. They're a complex city with big clones and subclones that are communicating with each other. Are there critical mutations present in the subclone that actually could cause resistance to a targeted therapy in the long term? Which mutation probably came first? And you can guesstimate this by looking at the size of the variant allele frequency from the sequencing report. Often you can ask and they can give you that information, whatever lab did the molecular pathology. Is the DNA damage repair pathway intact, or is it damaged? Is there likely to be lots of epigenetic diversity in the tumor? And that has big implications for prognosis and epigenetic therapy. And what I'm really looking for, are there synthetic lethal targets to the mutations that we see that could also be used in the patients? And are there neoepitopes? So these are new peptide sequences present that you don't normally find in human genes, human proteins. So this is a paper we've just recently published by Brooks Bernard, who a PhD student that I mentored at Stanford, and he took 3,000 acute myeloid leukemia sequencing data, and he found very unusual patterns of subclone and clone size across mutations across 3,000 patients. We don't really know why different mutations have these different patterns, but we believe it's very important. And you can also infer some synthetically lethal relationships, because often we find two mutations that never occur in the same tumor, suggesting the cell just cannot tolerate having both of them at the same time, and that's very useful for building new targeted therapy. One of the really strange things we noticed from this study is if there was lots of branching in the subclones of the tumor, so lots of different mutations that were not sequentially or serially acquired, the prognosis was really good. So you can see all of these patients had a branched evolution. In other words, their tumors were heterogeneous and seem to have acquired different subclones at different times rather than sequential evolution of a dominant clone. And you can infer these kinds of things when you look at sequencing reports. We've developed a new form of missile, which is a tool to mine for synthetic lethals, and we're now establishing ways to integrate these kind of bioinformatic tools with MDT, so that clinicians, molecular pathologists, clinical trialists can have access to other therapies they wouldn't normally think of if they were just looking for kinase mutations, for example, in tumors. Recently, the synthetic lethal work has caused us to discover a lot of metabolic genes that are synthetic lethal with a number of cancer mutations, and we've established a mass spec metabolomics and flux solution for South Australian researchers on level 6 of the SAMRI, and it will be open up as a core facility very soon. Martin Snell has just optimized it, but it will allow you to quite carefully dissect how the tumors, what fuels they're using for achieving growth. And what we and others have discovered is very unusual Krebs cycle metabolism is being used by many tumors, including pancreatic, breast, leukemia. One of the most important pathways that we've shown is changed in a number of cancers is called reductive carboxylation, and it's a pathway that occurs in the cytoplasm outside the mitochondria, but it's a way that the cancer can quickly give carbon for building new fatty acids. But the beauty of all these metabolic pathways that are reprogrammed in cancer is they are eminently targetable with drugs that are safe, and that's really exciting. We recently discovered a a way to target a neoepitope. This is the second most common mutation in a terrible precancerous condition called myelofibrosis, of which there is no curative or targeted therapy. We've been able to disrupt this neoepitope with an antibody by specifically targeting the fragment that binds the TPO receptor on the surface of the cell. So we're currently humanizing this, and we're hoping to put this in a phase 1/2 trial here run at SAMRI in the next 9 months. And we have some other repurposed drugs that we've discovered using bioinformatic algorithms, including meclizine for hepatobiliary cancers. We're really excited about this is the first precision medicine trial for another very poor prognosis blood cancer called chronic myelomonocytic leukemia, and this is being rolled out across Australia in 5 centres, and we've recruited a number of patients in the last 5 months, which has been tremendous. But basically, depending on their mutation status, they get access to medications that have good preclinical data to be effective. So watch this space. So in conclusion, I feel precision medicine in cancer has really only just begun outside of chronic myeloid leukemia, but the future is bright. There's many other ways that we can target mutations. Mutations are terribly important, but we need to look carefully at the epigenetic and metabolic profiles of all of these mutations. The ones you can see in pink are the ones that have come from our research group in the last 5 years. I really want to thank my incredible postdoc research assistants who work extremely hard. Chloe Thompson-Peach and Kelly Lim and Lisa Kahn, who is the clinical trial monitor at the SAMRI Clinical Trials Centre, and Dennis, who's a fantastic biochemist that I work closely with.
Fantastic. Thanks so much, Dan. I thought I might just ask you, as a clinician, it seems like, we've been interested in cancer metabolism for a long time, but very few agents have really crossed the divide into the clinic. What do you think's the limiting factor in translation of cancer metabolism to therapeutics?
I think, first of all, it was fear of serious toxicity, which is why most phase 3 or 2 trials fail. Big Pharma was afraid of targeting what they thought was essential enzymes in the liver. I think what has been really exciting from our own and others' work is many of these enzymes are not actually essential and can be targeted safely, but the tumours tend to use them at much higher levels. Obviously, the Agios compounds for IDH mutant cancers have been a good example of success, but they are really a neomorphic enzyme, small molecule inhibitor. So there was less chance of off-target effects. There's increasing evidence that metformin is playing a role. Obviously, asparaginase is a very effective metabolic agent we use in acute lymphoblastic leukemia. But I think watch this space, we're going to see many more repurposed and novel metabolic drugs in cancer.
And do you think the precision approach is going to apply metabolically? I mean, intuitively, we believe that's the case, but it's obviously a fair bit easier at the moment to detect a specific mutation than it is to detect a specific metabolic vulnerability in a patient. What do you think the future is there in terms of personalising metabolic therapies?
I think it'll depend where the consistency comes from. So obviously DNA, somatic mutation is an easy, reliable biomarker. We're only beginning to work out if that is a strong predictor of the cancer's metabolic reprogramming. I've certainly got good data for some of the leukemic mutations, give you consistent metabolic phenotypes that you could target, but it may be, we may need more sophisticated techniques to work out how a breast or a prostate cancer, for instance, is really gaining its nutrients and carbon. But I guarantee it'll be doing it in unusual ways, and that's good news for patients.
Yeah, agreed. And trying to predict those sort of, retaliatory responses of the cancer cell. Excellent. All right. Well, we might leave it there. Thanks so much, Dan, and thanks to Jordan as well, who will be watching the recording later. I think, you know, these two researchers have been a really phenomenal addition to our Adelaide Biomed City campus over the last couple of years, and, you know, I really encourage you to reach out to them. They're both very collaborative to learn more and to work closer together. So we've kept to time really well. So congratulations to both of you. I'm impressed. And thank you all for attending. It's been a great attendance today. So we'll see you next time.